Good morning and good afternoon. Welcome to the Weekend Wellness Hour show. I am very honored to have with us today Dr. Eberhard Samlowski, who is a friend of mine, and I've known him a couple years through an amazing mastermind with Kyle Wilson. And Eberhard has a heart of gold and has amazing information to share with us about wound care and infections today. And he started out his career as a board certified general surgeon for 20 years and then had to retire from due to some arthritis, and then went into wound care. And he's going to tell us kind of a little bit of his journey about getting there, because he has some stories that are very fascinating about wounds and trauma. And so I'm going to let him share on that. But thank you so much for joining us today, Eberhard. Really appreciate your time.
You're welcome.
So why don't you tell us a little bit about your journey of becoming a surgeon and then going into wound care specialty?
I did my surgery training, part of it at Baylor University in Houston, Texas, and then I finished up at Scott & White in Temple, Texas. But while I was in Houston is a major trauma center and cardiovascular center. So I trained with a bunch of world famous surgeons. I mean, at least 15 different world famous surgeons. And while there, you literally saw and did everything. While I was a resident, third-year resident, a guy came into the emergency room with a stab wound to the heart, technically dead, no pulse, no blood pressure. And we opened his chest in the ER and patched the hole enough to get him to the OR. And he walked out of the hospital 7 days later. So
oh my,
we did all kinds of crazy things. Fortunately, those were the days before AIDS and bad hepatitis, because we were covered in blood constantly.
Oh my gosh.
So it's one of those things that I trained at the right time, right place. I saw just about everything you could see. I saw full-blown tetanus, where we actually had 2 full-blown tetanus patients where we literally had to paralyze them, trach them, put a tracheostomy tube into them, and put them into a coma. Because the biggest cause of death in those tetanus patients is cardiac arrhythmias. Okay. And what we do is once a week sort of lighten them up and look for arrhythmias, and if we saw any, we put them back down. Wow. And both of them survived, and both of them, other than losing a month of their lives, did well. Sorry, my cat jumping around. I saw full-blown gas gangrene, and that's a tragedy, because it was a young motorcycle rider that slid on the pavement and just got a horrendous road rash. He was at another hospital and was transferred to us, literally dying. And wow. He ended up, he did die. Yeah. Then I was in Houston when we had the first literally Vibrio cases in the country, or what we call now flesh-eating bacteria. Okay. Where a guy was stung by a sea urchin down the Galveston Bay, and he came with a sea urchin sting to his finger, and within a couple hours he lost his finger. Within a couple hours he lost his arm. Within a couple hours he lost his arm, and ultimately they disarticulated his shoulder, moved the entire upper extremity, and then he died. And that was before they knew that was caused by a bacteria. They had never isolated the bacteria before. So you see the worst things, and if you can handle the worst, you can handle the simple things.
I can imagine it's hard to even make sense out of all that, and then to go into wound care. And at what point in your career, did you think you would ever end up in wound care, or is that just because you retired and you remembered how, your time at Baylor?
It's the last thing I planned on doing. Okay. Because the best technical surgeon I ever worked with was 80 years old. I mean, he was unbelievably gifted. So I always saw myself as either an academic surgeon retiring at age 80. But unfortunately, I was very active. I was a skydiver, scuba diver, did triathlons, did all kinds of overuse things. I was an expert snow skier. And standing on hard concrete floors for 16, 18 hours a day is not good for the hips. That was before they had foam pads. And unfortunately, my one hip went bad. And during the surgery, they injured my ulnar nerve from positioning, which caused 2 of my fingers to be numb. And they said, oh, that'll come back within a couple months. And never came back. Here it is 12 years later and the fingers are still numb.
Wow.
Well, I have
Oh, wow.
I call them paresthesias. They're just weird feelings in that finger.
Yeah.
And then my other hips went bad. So, I'm an entrepreneur. So I thought, I'm going to do real estate and other things and just keep active. But something just kept driving me back. I was sitting home. I spent all this time training and I just felt like I needed to do something. And I stumbled upon wound care, and it's the closest thing to surgery that I found.
Yeah. Yeah. And now, do you have a practice, or in what setting do you do wound care right now?
I'm a consultant.
Okay.
I've been asked to work in a clinic setting multiple times, but I used to work for a multi-specialty clinic with 100 employees, and we spent every month dealing with employee issues and billing issues and this and that. I said, I never want to do that again. So now I work for a company that is mainly in the nursing home setting. And most people think, oh, it's just elderly. You'd be amazed at how many young diabetics, how many young stroke patients, how many quadriplegic, paraplegics I deal with. So it's not just old people.
Okay.
So it's just basically a nursing home setting.
Okay. And then, so now you deal with, I imagine, a little bit more complicated wounds though, right?
Yeah,
Beyond the
mainly what
basic.
I deal with the severe venous ulcers, severe arterial ulcers, severe pressure ulcers. And I've sort of been banned from Facebook from posting some of those pictures and results because they're considered violent content now.
That's too bad, because they're educational, and those of us who are not familiar with ulcers and how they develop, and you can learn a lot from seeing how those ulcers can heal and learn from you. So that's too bad, but yeah, I guess it's graphic, so I guess that's a problem for some people, I guess. So let's go into what are the different types of wounds, maybe some general categories, and then we'll look at some like maybe basic wound care.
Okay, the most common wounds that we see in the normal population are what are considered traumatic wounds. The cuts and slices and things like that. But things I deal with are the pressure ulcers, the vascular ulcers, whether they be arterial, venous, or lymphatic. The diabetic ulcers, and then unfortunately the malignant wounds. And that's pretty much all the classification of the wounds. Okay.
And so if we're looking at kind of more the traumatic and kind of the basic, what is kind of like some of the basic care for, cuts and scrapes and those types of things?
Yeah, traumatic wounds are usually treated with what we call a primary intention, or, suturing, if they're deep enough. The first thing you have to do is obviously clean the wound out, get any debris out. There is still a use of hydrogen peroxide initially to get some of that stuff out. Hydrogen peroxide is considered toxic to the tissues, so it's not for long-term use. It's not something you want to continue. Then a lot of people, once the wound's either closed or if it's a burn or something like that, then you use some sort of topical. The cheapest, best topical out there now is a product called Anasept, Anasept. It's over the counter. It's basically sodium hypochlorite, which is basically a dilute Clorox. Years ago, we used a solution called Dakin's, which was a more concentrated form of the sodium hypochlorite. And it fell into disfavor because it caused delayed wound healing or retarded wound healing because it was toxic to the tissues. And this company came out and figured out that if you put it in a gel form and dilute it out more, that it kills 99% of bacteria, causes no resistance, and it doesn't retard wound healing, which meets all the criteria you want for wounds. You can buy it on Amazon for about $30 a tube. The problem with Neosporin, bacitracin, all these other antibiotics is they cause resistance. So you create resistance bugs, and in today's society, especially with MRSA and some of the other bugs out there, you want to limit the resistance as much as possible.
Okay. So getting something like this Anasept, you don't have to worry about that as much
No,
or at
not at
all.
all.
Okay.
Not at
Oh,
all.
that's wonderful. Yeah, I haven't even heard of Anasept, so this is
Yeah,
great.
most wound care doctors haven't heard of it.
Okay. And so when you apply that to a wound, is it a very thin covering, or do
Yeah,
you rub it
so
in, just kind of smooth it over?
yeah, it's just a very thin gel, and
Okay.
it's clear, and it doesn't take
Okay.
much. It takes a drop, literally.
Okay. Wow. That's incredible. And so then I have a question for you. So I'm an avid runner, which I think you're familiar with. And a lot of times when you're out on the trails, you fall and you bust open your knee and you get a lot of debris in there. And there are times where it's kind of embedded. So, and it's hard to get that out, especially when it's very raw. So something like that, do you still try to get it out under running water, or do you let it just sit for a bit?
Yeah, you try to get it out as soon as possible, either running water or just gentle using a gauze pad, try to get it out. But
Okay.
if it doesn't come out, then it'll work itself out. The body's good about getting rid of debris.
Yeah. Okay. So in the worst case scenario, if you have to leave some rocks in there embedded in your skin, it's okay.
Oh
As,
yeah.
in that situation, would you pour some hydrogen peroxide over the wound?
Yeah, initially you can use some peroxide to help.
Okay. Okay.
What peroxide is basically H2O2. I mean, so the what happens with hydrogen peroxide, the way it works, and the reason it bubbles
Mm-hmm.
is all living tissue. You could pour hydrogen peroxide on a cut potato and it'll bubble. You
Okay.
can cut any living tissue. All living tissue has catalase in it, and it splits the hydrogen peroxide into oxygen and water, and that's what the bubbling you see. And that reaction occurs millions of times in a second. So
Okay.
that's why it foams and bubbles and clean. And it's a mechanical cleaning, and the high concentration of oxygen is toxic to the gram negative anaerobic bacteria.
Okay. Okay. And that's what kills it. So that's how
Yeah.
we clean it. Okay. So that's interesting. And so then how do you know when to cover a wound or not cover it?
If it's a simple little wound, as I
Mm-hmm.
said, if you use Anasept, it creates this gel that actually hardens and is
Okay.
clear over it. So I leave a lot of wounds more open than I used to. Now the
Okay.
wounds I deal with, they have so much drainage that you have to cover them. I mean,
Mm-hmm.
any weeping wound you want to cover, just because
Okay.
bacteria love to live in that stuff. So you want to cover those wounds. But
Okay.
a simple little laceration, there's really no reason to cover them.
Okay. Okay. That's good to know. And when some wounds develop scabs, often people like to pick them and pull them off, which is a common human trait. How damaging is that to a wound? And you hear the advice, don't pick at your scab. Okay, how relevant is that?
Okay, as a surgeon, I pick scabs with a scalpel.
Right.
The problem with scabs is they contain the toxic byproducts of the macrophages and everything. Macrophages, they eat the bacteria, but the way they kill the bacteria is they release all kinds of toxic substances, and those stay
Okay.
in the wound and they actually become part of the scab. So there's all kinds of studies that show that if you remove the scab, and if you remove it about weekly, it's actually speeds up wound healing.
Oh, wow.
The problem is most people pick their scabs with their dirty fingernails, which have all kinds of bacteria underneath it.
Got it.
And that introduces bacteria into the wound, and that's what causes the problem. So if you have a clean scalpel or a clean instrument and you pick the scab off, it's fine.
So our innate tendency to pick scabs is actually a good thing as long as we use clean instruments. That's
Yeah.
amazing. Okay. Wow, that's wonderful. And then with bandages, if you do have to apply a bandage, there's a lot of different types, but with a small laceration, if you do have to cover it, if it's still bleeding or whatever, regular bandage, do you recommend gauze? What do you recommend?
It really doesn't matter.
Okay.
I mean, I found over the last 10 years that the dressing is less important than the debridement and the treatment. So you there are certain reasons you put certain dressings on. If it's a moist wound or wet wound that's weeping a lot, you want to put a dressing on that absorbs. If it's a dry wound, you want to keep it a little bit moist, so something that retains moisture. So something that's got a little plastic film, like a Band-Aid with plastic covering, that's the rationale behind all that. But in terms of, does it really make a difference? The dressing is probably the least important thing.
Okay. When you're in, a quick question about wound cleaning. When you're cleaning a wound, does it matter if you use saline to squirt on the wound or running water? Does that
really
make a difference?
Matter.
Okay.
Nah.
Okay. And then do you use silver? Because I've heard silver is good for wounds. So when would you use that if you use it at all?
Silver is a bacteriostatic agent. It doesn't kill bacteria, but it inhibits them from growing. So the biggest place that we use silver is in burns. We use sulfur sulfasalidine, and we use it in venous type ulcers that have the cellulitis associated with the venous ulcers. But for a routine wound, doesn't need silver.
Overkill then for us. Okay. So what happens in the process of a wound becoming, acute and short-lived to chronic? What's going on there?
Wounds go through a process of you start out with hemostasis, where obviously the fresh wound, you want to stop the bleeding, so the body naturally releases platelets and things, and they release substances that bring in the macrophages. Then you have the inflammatory phase, where you see the redness and things like that. Then you go through a proliferative phase, where the fibroblasts start producing new collagen and things like that. And then you go through a maturation phase. And what happens with acute wounds are not a big problem. What happens is, when the wounds become chronic, the body literally stops healing because it sort of thinks it's healed itself. And so what we do as wound physicians is we try to keep the wound in an acute phase. And that's why we debride once a week or so, to keep the wound fresh. So the body's constantly thinking, oh, we got a fresh wound, we got to keep healing it.
Got it. Okay. Why don't wounds heal like in these situations? Is it a specific condition of a person, or is it something that they're doing that's not allowing the body to heal, or is the body just doesn't have a good healing system?
It's so multifactorial. I mean, there's for things I deal with, like pressure ulcers, ongoing pressure where people aren't offloaded, where there's still pressure on the wound, which continues that whole process. There's age involvement. As we age, our cells don't multiply as fast, so the healing process slows down. There's oxygenation levels in our body. As some people get older or they're smokers, the blood supply to their tissues is decreased. Then you got the diabetes. Again, you're talking the vascular issues. And I deal with a lot of diabetics. About half the nursing home population is diabetic. I mean, it's that high.
Oh, wow.
So, and a lot of it's adult onset diabetes. That's their own fault, is diet related.
Yeah.
And then you got lymphatic issues, where blood can't get out of or the fluid can't get out of the tissues. So it's really multifactorial. I mean, you can't usually pinpoint to one thing. Nutrition is a huge factor. A lot of these people have vitamin deficiencies, they have protein deficiencies, they're not eating, and trauma, people underestimate, like major trauma, the calorie requirements required, because the body's expending so much energy trying to heal the wound, that a lot of people, even though you look at them, they say, oh, they look healthy, but they're actually nutritionally deprived.
Okay. So when you talk about nutrition, what are some of the things that you encourage people for their diet, or what vitamins do you recommend?
Vitamin C is required for collagen synthesis and So it's a easy water soluble vitamin. You can buy it on any pill.
Yeah.
Zinc is required. It's the same thing with copper. They're anything that you can get in a regular multivitamin.
Okay.
Vitamin E. Now, vitamin E hasn't been shown to be very helpful in chronic, the pressure wounds.
Mm-hmm.
But for a simple dermal injury, there's no question that vitamin E helps. It helps with collagen synthesis and things like that. So,
okay,
it's just a simple little vitamins. In what I do, we get a lot of what we call intractable itching patients, or people that itch like crazy and they create their own wounds by scratching. And as you get older, a lot of people, about 50% of the population, develops antibodies to the protein that absorbs vitamin B. So vitamin B is necessary for myelination of the skin. So, and I found this totally by accident. And so anytime I see a patient that's itching like crazy, I automatically put them on vitamin B, and I've been amazed at the results of that.
Wow, that's incredible.
And what happens too with wounds is, especially bad wounds, you've got denuded nerve endings sticking in the wound, and the vitamin B just helps remyelinate those nerve endings.
Okay.
So,
Okay. Wow. Which is especially important. Also, a lot of people have gone to plant-based eating. I can imagine, I mean, they talk about vitamin B12, but I can see also why it's really critical to have vitamin B now for your skin and healing. That's incredible. Because you hear about B vitamins for energy, but not necessarily for skin.
Oh yeah. And I've often wondered, these people that talk about itching in the winter and, itchy skin.
Yeah.
I mean, I have no proof that it makes a difference, but I'd think about it.
Yeah. Oh, that's incredible. Huh. So what about for food wise? Kind of, is there anything specific foods, like certain vegetables or plants or proteins, anything specific?
Any severe injury, you want to have a high protein diet, anything with a lot of protein in it, because the body's metabolizing it and turning into collagen.
Okay.
So anything like that. Carbohydrates, just because especially, I deal with a lot of venous ulcers where the legs are just weeping like crazy.
Okay.
And the fluid loss from those and the protein loss from those is tremendous. And so you got to replace that stuff. And a lot of like nursing homes, they give supplemental arginate or different protein products.
Mm-hmm. And how harmful is caffeine? You hear it delays healing. How harmful is that? Can you tell?
I don't have any experience because I don't control caffeine use.
Yeah.
So there's no randomized study that says it's good or bad.
Okay.
I mean, the only thing I would think is caffeine is a vasoconstrictor, and a vasoconstrictor, especially in the extremities, would decrease blood flow, which would decrease oxygenation. And so that's the only thing I can postulate, but I don't have any proof.
Okay. I was just curious about that. And also, a lot of times when we have wounds, at least after an injury, there's a lot of swelling. So that excess swelling, does that delay healing, or can you do massage to help with that? What are some options?
Yeah, there's definitely, anytime you've got swelling or you're disrupting the blood flow to the tissues. So like sprained ankles, there's no question that when I was in college, I was an athlete and I played soccer, and I had an ankle injury, and we did hot and cold therapy where it was miserable, but you could literally feel your leg expanding, contracting, and they use it a lot on the big athletes, and it definitely makes a difference, increasing blood flow.
Okay.
So I anything you can do to reduce swelling would help, because what people don't realize is oxygen is a very large molecule. It can only diffuse a few centimeters in the tissue, or actually a few millimeters, versus CO2 is a very small molecule and it can diffuse several centimeters.
Okay.
So the problem is getting the oxygen to the damaged tissues.
Okay.
And
So
that's
if,
what we do with debriding eschars too. Black tissue. One of the reasons they don't heal is oxygen can't get underneath the eschars, spreads the surrounding tissues.
okay.
And a study, hyperbarics has never been proven to be very effective except for certain transplantation things and other things. But for most wounds, it's been a failure. It's a very expensive treatment. It's about $10,000 a treatment. And so most people can't afford it.
Mhm.
And I think the problem is, and like I said, I'm not in a research mode anymore. I'm old and don't care anymore. But I've always postulated that it's because the oxygen can't diffuse through the tissues. And I've always said, I wonder what would happen if you debride the wounds before they went to the oxygen chamber, if that would make a difference. But I'm too
Yeah.
old to do that research.
You just suggest it to someone else and say,
Yeah,
please go take care of this.
I don't
So,
write papers anymore.
got it. Now, when you see swelling, is it okay to do some massage as long as you're not touching the wound and you're staying outside the borders of the
Oh
bandage
yeah,
and the wound? I mean,
yeah,
to help with swelling and moving
yeah,
tissue, moving fluid
I have
along.
that.
Okay.
Yeah, I have absolutely no problem with that.
Okay. And then you said for like a healthy wound in the inflammatory stage, you should have some redness because a lot of times people start to get worried when they see redness and think, oh, infection.
No, all wounds are get colonized.
Mhm.
Now, in terms of the wounds I deal with, a high percentage of those have what we call biofilm, which you can't see. And that's why the Anasept works so well, because it kills 99% of bacteria. But for a normal, healthy wound, granulation tissue is normally beefy red. So you want to see beefy red tissue and you want to see red. So
Okay.
red doesn't bother me. It's when the wounds are yellow or black that I worry. Yellow indicates that there's a lot of slough, which indicates probably bacterial overgrowth mixed with fibrin byproducts, macrophage byproducts, and black is just dead tissue.
Okay.
And but red
Okay.
doesn't bother me. Now, if there's a huge amount of cellulitis around the wound, yeah, then you start worrying. Where you
Okay.
think about the redness, heat, pain, those are things of where you're looking for ongoing infection.
Okay. So when a wound is chronic, doesn't necessarily mean it's infected per
No,
se, correct? And what are some of the other signs and symptoms that our wound is infected? So the
usually there's a lot of pain associated with it, or the redness. I mean, the cellulitis around it,
okay.
and obviously smell too.
Okay.
Infected wounds have a smell to them.
Mhm.
And my background is microbiology, and certain bacteria have certain smells. Like Pseudomonas has a sickly sweet smell. So,
Oh,
and they turn the bandages greenish.
okay.
So now Pseudomonas is usually a colonizer. It usually doesn't cause. It's usually not invasive, but bacteria. Most wounds, unfortunately, because the nursing home population I deal with, a lot of wounds have the fecal bacteria in them,
Okay.
and everybody says people don't realize bacteria don't stay put.
Yeah.
So you can have a foot wound that's 5 feet away or 3 feet away from the butt wound, and it's got the same bacteria as the butt wound.
Got it. Got it. And
Uh,
at a certain point, when it gets to enough bacteria in there, or the bacteria has grown enough, that's when it becomes infected.
oh yeah,
Okay.
and yeah, there's a certain amount of bacteria per gram of tissue that's required for it to be considered infected. But like I said, we call it biofilm. All wounds are colonized. I mean,
Okay.
people don't realize how many bacteria are in the human body,
Okay.
and most of them don't cause a problem. But that's what I love about the Anasept. It clears all that crap out.
That's incredible. And with the Anasept, you put that on immediately after cleaning the wound, right?
Yeah, it's part of the dressing. We mix for the bad wounds that I deal with. We mix collagen granules with the Anasept. It creates a paste, and it literally kills the bacteria, and the collagen granules give the macrophages a matrix to break down. It takes the collagen, remodels it, and creates new collagen. And
Oh, wow.
brings in healthy tissue.
That's incredible. And is that for more like the bigger pressure ulcers or venous ulcers, or is that something that you can use in an everyday cut where you mix the granules with the Anasept?
Yeah, for a cut that's closed by suture, you don't need it.
Okay.
But if you have a wound with tissue loss, yeah, then it's useful. Now, I don't know how easy collagen granules are to get over the counter. I mean, Anasept you can buy on Amazon.
Mm-hmm. Okay.
But for me, it's easy to get it, but it's,
yeah, you have special people that can get them for you, right?
Oh yeah.
Right.
And I see, these products never expire, but nursing homes are forced to throw things away on expiration dates. So millions and millions of dollars are wasted. So I collect unused stuff and send it to third world countries because, like I said, there's no expiration on collagen. It doesn't go away. I mean, there's no expiration on these dressings. I mean, as long as the packaging is intact, there's nothing wrong with it. Mm-hmm. And it's crazy the millions of dollars we waste in this country.
A lot, yes. In many different industries, not just this one. Many different.
Oh yeah.
Yeah. So, what are some of the common types of infections that we would see kind of, in the general population?
The biggest thing I see, I was around when the MRSA infections first started, mm-hmm. the drug-resistant Staph aureus infections, and unfortunately, the spiders get blamed for most of them. I can't tell you how many hundreds of patients I've had. I have a spider bite, and I said, bullshit. It's not the poor spider. It's you got a skin infection from MRSA. Now, MRSA infections are interesting because it's not a typical staph infection. They just got yellow pus, and then you pop the pimple, and the pus comes out.
Yeah.
MRSA actually forms a central core, and you got to get that core out to fight the infection.
Got it.
And what I do with MRSA infection, I remember when the babies first started coming out with these huge abscesses. Mm-hmm. I mean, these abscesses were half the size of the kid. I mean, it was unbelievable. So you didn't size them. And one of the things I did as a surgeon, I created a solution which was 1/10 hydrogen peroxide. It was 1 part of betadine mixed with 9 parts of hydrogen peroxide, and I'd clean out these abscesses with that. And you just do it 1 time, and I never had a recurrence of these abscesses. I did the same thing with perirectal abscesses. I treated hundreds of perirectal abscesses and did the same thing and never had a recurrence. Wow. But again, you only do it the first time because those products are toxic to the tissues or healing tissues. So you don't do it over and over.
Okay. But at least it gets the bacterial infection out of there, and then
what we do as surgeons, most people don't realize everything a surgeon does is destructive. Yeah. We're not building things, we're destroying things. I mean, we're taking bad things out, and we're giving the body a chance to heal. And because the body's miraculous. I mean, without the miraculous healing abilities of the body, we wouldn't be able to do what we do.
Right.
So, for example, when I take out a nasty appendix or take out a nasty gallbladder, I'm taking out something. I'm not putting something in.
Yeah.
So I'm just giving the body a chance to fight whatever's going on.
Right. Giving it a lift a little bit. And sometimes we need that. Sometimes otherwise it goes downhill, and we're grateful that we have people like you who can give it a jump start to get back to healing correctly.
Yeah. And then with wounds, a lot of it, part of my job is to figure out why did you get the wound to start with.
Right.
Like the biggest problem with venous ulcers is most of them are self-induced.
Oh.
I mean, a lot of the population is obese. Mm-hmm. I mean, I deal with some 350, 400, 500 pounders. A lot of them have been smokers or drinkers. A lot of them are diabetic.
Okay.
But the bigger factor is a lot of them don't elevate their legs. And I get patients all the time that have been sleeping in recliners for years or sitting in a wheelchair for hours at a time. And the best treatment for these patients is lay down in the bed with your legs elevated for 1 hour after each meal and at bedtime. And you can heal almost 100% of these ulcers.
Oh, wow.
And just by changing what their behavior is. Now, I had to breed them and I do other things, do the other treatments. Yeah. But a lot of them, the same thing with venous. Now, the other thing that's neat about it started out with lymphatic ulcers or lymphatic problems where they had the compression devices. Mm-hmm. And unfortunately, the medical compression devices cost $1,000 and most people can't afford them. But here in the last couple of years, there's all kinds of companies that sell compression devices for athletes to in the recovery phase that pump the legs and get the fluids back out of the legs. Mm-hmm. And you can buy some of that stuff for $150, $175, and they're pretty decent. Okay. And those things make a difference.
Wow. And what about sleep? So we have a big insomnia problem in the country. Does sleep matter for wounds and how they heal? And
I don't know sleep per se, but oxygen levels do. Okay. And we do know that oxygen levels are probably decreased a little bit during sleep, especially with and nobody's really studied this yet, but the people with sleep apnea, where they become hypercarbic and hypoxic, my gut feeling is they have problems with wound healing. Okay. But there's no big study ever been done on it. So, but I've thought about it for myself, just having a little oxygen concentrator and increasing the oxygen at nighttime.
Yeah. Yeah. Especially
not that I'm Michael Jackson and want to sleep in an oxygen tent, but
no, you don't. Why not? So what about being stationary versus movement? So obviously if we're moving, we're going to get more blood flow. So do you recommend when people have a bigger wound that they try to move, their fingers or toes below that wound if it's, on an arm or leg?
Yeah, we know that from the astronaut studies that human beings aren't meant to be sedentary. Yeah. And as soon as you're sedentary, you get bone demineralization, you get all kinds of other things that happen to you. Yeah. So walking or any type of exercise or any type of muscle movement, just the movement of the muscles compresses the lymphatics and pushes that fluid back to the heart. So any type of activity is beneficial for wounds or anything else. Okay.
So a lot of different ways that we can help promote wound healing, including diet and movement and trying to get rid of some of these other conditions. And I know diabetes is a hard thing and losing weight is hard, but those are definitely options that people can choose to do.
Oh yeah, diabetics, if your hemoglobin A1C is above 8, it's very hard to heal a wound just because of the sugar content in your bloodstream. Okay.
Wow, this is incredible. Are there any other tips that you would recommend for people to know for healing or wounds or infections to look out for?
Just for the average person, again, I've been in medicine for 35 years now. So some of it's intuitive, some of it is just experience. And like I said, what I told you is I pray that God, please show me things that other people don't see. Yeah. Years ago, for people that had leaking gastric tubes and other things, we used to use Malox to sort of buffer the acid and stuff. And it turns out, and I came about this totally by accident, that for people with moisture dermatitis or people with diaper dermatitis, it works great for babies. That Malox, just paint the butt with take a cotton swab, paint it with Malox. And the reason it works is Malox is a buffer. Okay. And people that have urinary incontinence or babies that are peeing their diaper, the urine breaks down to urea, which breaks down to nitrogen. I mean, not nitrogen, it breaks down to ammonia. And ammonia has a pH of around 11, 12, which is caustic. It'll burn your skin just like cement burns cement workers. That's why you see cement workers with cement burns.
Yeah.
And the same thing with diarrhea. Diarrhea is very acidic. So what happens is diarrhea, and it has bile salts in it, which are very corrosive to the skin. And what the Maalox, and the pH of diarrhea is usually around 2 to 3. It's just like an acid.
Okay.
So what the Maalox does, it being a buffer, it'll drop the pH of the alkaline wounds or the alkaline substances down to a pH around 8, 9, or it'll raise the pH on acidic stuff to 4 or 5. So it's a lot less irritating. Plus it dries on the skin. It's protective. So very effective. And the same thing, and I deal with a lot of moisture in the population I do. So highly effective in treating that. And then the other thing is, I was taught by one of my college I studied fungal diseases. So one of my mycology professors always said that fungal diseases are totally underestimated in our population, that fungus is totally underrepresented. So in my population, there's a lot of fungal component and it's easy to treat with miconazole. 2% miconazole takes care of it. So people with breakdown on their chronic wounds in their butt, we mix Maalox with miconazole, and it's highly. Most nursing homes won't even call me for routine buttock wounds anymore. They just start painting with Maalox, and it goes away.
Oh, that's wonderful. It gets the healing process started faster then too.
So it's one of those things where people, when I first tell them, they laugh at me and say, "Oh, that's off formulary use, and it's off." I said, you're painting the skin. I mean, it's no big deal."
Yeah.
So and once they start doing it, they never stop.
Okay. And that's good because they see the results and they're like, okay, I can do this.
And for babies, it works great.
That's incredible. And do you keep, like, for a baby who has a diaper rash, how often do you apply that? And after every time to go?
After every bowel movement or after every urinary, whenever the diaper's wet. Just
put it on again.
And it's soothing. It's very soothing.
Okay.
It doesn't burn.
That's incredible. And one other question: when do people need to seek help? Like, let's say they get a wound cut. Sometimes you don't know. You're looking at this laceration or a wound. At what point are there any common tips that you would say, hey, okay, you need to go see a wound specialist?
Well, wound specialists usually you're dealing with more chronic wounds. I mean, the typical, burn or scrape. I mean, a first, second degree burn, it doesn't matter what you do to it, they're going to heal.
Yeah.
But it's the third degree plus that you need to seek help.
Okay.
So, and the same thing with cuts. I mean, simple lacerations, you don't need me.
Yeah.
So most of those, ER doctor or your regular family practitioner can take care of that. I deal with the stuff that it's way beyond them. And wound care has become a true specialty. I mean, it's most physicians, actually, the ones I deal with, don't even want to know what I do. They just say, go do it and take care of my patients.
Yeah.
There's
a lot of knowledge.
Doing that stuff.
Right. So, and it's good. I would rather see someone like you if I have a pressure ulcer or something that's not healing. But I want someone who deals with this all day long, and what works out there, what doesn't. Like these little tips with Maalox, that's incredible.
Oh yeah, there's just little things that you pick up, and like I said, there's some intuition that comes with it. I can look at a wound and pretty quickly figure out what caused it and why it's there, and what the best treatment, or at least. And they call me Mikey in my group because I'm always willing to try things. So as long as I stay innovative and stay on the cutting edge, I won't retire. But it's, I just try to just stay up with what's current. And unfortunately, I have to deal with real life situations about the government controls everything, and reimbursements for wounds, especially in the elderly population, Medicare, you have to be cost effective. There are some neat treatments out there, potentially the amniotic tissue that's the treatments are so expensive that no nursing home or no elderly person could ever afford it.
Okay.
So I have to be cost effective in what I do. So that controls a lot of what I do.
Right.
I mean, we have all kinds of neat potential treatments that are out there, but they're so cost prohibitive, you can't do them.
Yeah. So obviously you provide a consulting service and you're in Texas. If people want to reach out to you, so maybe the layperson who's listening to this, they got a lot of information on wound care, but maybe there's other specialists out there that may say, hey, we need a consult, with you. Is there a good way to reach you?
Yeah, unfortunately, I don't do nationwide consult. I'm licensed in Texas only. So, but I have had people contact me from around the country, and I will tell them what I would do. It's not advice, not
right.
It's sort of saying this is what I would do, but I can't give them specific information. And that's just because of the stupid laws in our country about licensure. I can't. Yeah. I'm like I said, I'm just licensed in Texas now. Right. I used to maintain my some other licenses, but I don't practice in those states anymore.
Yeah, and I know you actually did help a friend of mine who had some kind of skin thing happen to his face, and you said, hey, this is what the doctor in Arizona should be looking at, and sure enough, you helped and you gave the right advice. My friend got the correct antibiotic or whatever it was, and it went away. So
I do that kind of stuff where somebody says, can you help? And I just say, this is what I have a friend that lives in Florida. His dad had a foot ulcer that was being a little mistreated, and I suggested some things to him, and he was able to go to the doctor and convince him to change the treatments a little bit. So that's that wonderful. Kind of stuff I can do.
Okay. Was there a good way that people can reach you through Facebook or email? Is there a way that you prefer?
Yeah, my email, the email, my regular email. The problem is I get so many hundreds of messages through that. I might not see it for a while. So I do have a specific email that I use for more this type stuff. I use it more for my entrepreneurial stuff. And it's Samlowski@hotmail.com. EBSAMLWSKI@hotmail.com.
Okay, thank you.
But even that one I only check probably once a week. So it's not one I check frequently.
Okay, so basically they need to Facebook stalk you.
Yeah, they can stalk me.
Like I do. Bug you that way. So, well, I really appreciate you coming on today and sharing this great information, so many tips, and I took a few notes as well. And of course, this will be up on social media. So I really appreciate your time. Thank you so much for coming on, Eberhard.
No problem.
Okay. Thank you all for joining us today. We hope you learned a lot. I know I did. And we'll see you again next week. Take care and goodbye.